Obstructive sleep apnea happens when you're deep asleep. So you've no control over it, and your airway either closes in fully, which is an obstruction. So if your airway obstructs, your brain will say, breathe, 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 breathe. And then it partially obstructs, and you get that snoring sound or that snorting sound, and that's a hypopnea. So apnea is full closure, hypopnea is partial closure in your airway. And that's very much what we measure along with oxygen and flow when we do sleep studies to test for obstructive sleep apnea. So we're measuring the apneas and we're measuring the hypopneas, how long they last for and how often they happen every hour. And that's called an apnea and hypopnea index. And a normal apnea and hypopnea index scores 0 to 5. And that means that there is no evidence of obstructive sleep apnea if you score 0 to 5. 5 to 15 is mild obstructive sleep apnea. 15 to 30 is moderate obstructive sleep apnea. And greater than 30 is severe obstructive sleep apnea. So when you have a sleep study done and you come back to my clinic, I'm going to be telling you whether you do or you don't have it, and if you do or you don't have it, what category you're in and what that means for you. So for a lot of people, mild obstructive sleep apnea, we don't treat at all. For some people with moderate obstructive sleep apnea, we may treat because of their other comorbidities, their other health issues, and we certainly try and treat all obstructive sleep apnea. So what brings people to us? I'm doing this about 10 years now, but because I have my own clinic now, I suppose you're much more invested in it. But 10 years ago, what brought everyone to the door was a partner. It was always a wife, a partner, somebody, because somebody was snoring. It was always somebody else that was pushing them in the door. And snoring is one of the symptoms. But it does not mean because you snore, you have obstructive sleep apnea. You can snore and not have obstructive sleep apnea. But I suppose it's one of the big signs that tells people it may be a possibility, or their partner is saying, well, they're snoring really heavily. And then during the night, they stop breathing and I have to give them a little dig to get them going again. That's another one of the signs. Other symptoms of obstructive sleep apnea are headaches, bad headaches in the morning. Sleepiness, it's a sleepiness illness. So you're falling asleep a lot during the day. You find it hard to sit down without falling asleep. Driving particularly, sleepy drivers, lack of energy, bit of brain fog, lack of motivation. But really, one of the scores we do to assess people is called an Epworth score. It's an Epworth sleepiness score. And really, true sleep apneics score very high on that because they've spent their life trying not to fall asleep when they sit down after their dinner, watching the telly, you know, in very boring company, and then the driving. So sleep studies, a couple of years ago, before COVID, we had something called full polysomnography. Full polysomnography were very much the gold standard for sleep studies. And they measured those apneas, hypopneas, oxygen flow, but they also measured brain activity and limb activity. But unfortunately, in the Midwest, as any of you know, beds in Limerick Regional are very scarce or anywhere else. So to do full polysomnography, you need a hospital bed. So we haven't been able to do them. So we're very lucky that a company does our sleep studies for us in a nursing home in Cratloe. So you go in of an evening, they put on their equipment, you stay the night and you leave in the morning. And we're also extremely lucky that we have a very good sleep scientist who reports on our sleep studies. And I work with Dr. Aidan O'Brien, and he's a specialist in obstructive sleep apnea as well. So when we get your results, sorry, there's someone else coming in, Connor. When we get your results, it has been done. It has been assessed by the sleep scientist, and it has been assessed by the consultant. So, which is lovely to think the two heads have looked at the sleep study by the time I give the result. So, as I say, when you come back, then I'll either tell you you do or you don't have it, as to what degree you have it, and also do a full assessment to see what risks you are. Because outside of the aesthetics of sleeping, you know, the snoring and the disturbing and all that, we're really much more focused in the big picture, your overall health. Because if you have obstructive sleep apnea, your body is working very, very hard when it should be down in slumber deep. It should be sleeping and resting. And sleep and rest is fundamental for repair and for recovery. So if your organs are working very hard when they should be repairing and recovering, that has big implications. So we now know that obstructive sleep apnea makes blood pressure worse. Risk of cardiovascular disease is worse. My referrals now are coming from cardiologists, diabetic doctors, people with chronic diseases already, where the organs are already working hard, and they want to make sure that these people do not have obstructive sleep apnea on top of all of that. Now, the other thing that I want to rule out and rule in, just general myths about obstructive sleep apnea, would be, you know, everyone thinks it's a weight-related issue. And while weight does add to the risk of obstructive sleep apnea, it's not always the cause. So being overweight does not equals you have obstructive sleep apnea, but if you do, it adds to it exponentially. It's like throwing petrol into the fire, it makes it worse. But about 35% of the population of normal weight have obstructive sleep apnea as well. And then where it becomes very serious for people are people with jobs like driving jobs. They have to get tested and they have to be compliant with their treatment, because the RSA have rules around that and they could put them off the road if they weren't. Now, I know that all that sounds a bit dramatic, but the glorious thing about obstructive sleep apnea, it's completely treatable. So it's what we say, it's a mechanical problem and it needs a mechanical fix. So we can't give you a tablet for it, and we can't give you a paste for it, and we can't give you a therapy for it. But wearing CPAP, which stands for Continuous Positive Airway Pressure. I'm not sure if any of you wear CPAPs or BiPAPs. Continuous Positive Airway Pressure. So basically, we breathe at negative pressure. We're all breathing now. Nothing is pushing air in and out of our lungs. Continuous positive airway pressure pushes air in at a positive pressure. When we measure pressure in the lungs, we're measuring it in centimeters of water. So anything above 6 centimeters of water gives us positive pressure. That splints open that airway that gets blocked and does not allow it to collapse. And wearing that 90% of your time for longer than 5 hours a night is complete treatment for obstructive sleep apnea. And it works. And the machines have got better and better and better as time has gone on. And the information is transferable and the data is transferable, and it works very, very well. So that is fundamentally what obstructive sleep apnea is. Now, in relation to pulmonary fibrosis and interstitial lung disease, you're no more at risk of it than any other person. But you could be at risk of it for all other sorts of reasons. But the fact that you have pulmonary fibrosis doesn't put you any more at risk of it. And maybe some of you already know you have obstructive sleep apnea and you're on CPAP machines and you have your own experience of them. I don't know. But I hope my explanation is clear. I hope some of the symptoms are clear and the treatment is clear.